Here you can learn the concepts related to hypoglycemia, its definition, clinical manifestations, management, and so on. Let's start with introduction and definition. Hypoglycemia refers to the reduction in plasma glucose concentration to a level that may induce symptoms or signs such as altered mental status and/or sympathetic nervous system stimulation. There is no universal definition of hypoglycemia. When hypoglycemia develops in people without diabetes, it is called spontaneous hypoglycemia. Hypoglycemia has been defined by the American Diabetes Association in 3 distinct levels. Level 1 hypoglycemia, alert value, is defined as less than 3.9 millimoles per liter but greater than or equal to 3.0 millimoles per liter, that is, less than 70 milligrams per deciliter but greater than or equal to 54 milligrams per deciliter. Level 2 hypoglycemia, clinically significant, is defined as less than 3.0 millimoles per liter, that is, less than 54 milligrams per deciliter. This level is unequivocally low and suggests clinically important biochemical hypoglycemia. Level 3 hypoglycemia, severe, is defined as any low blood glucose level leading to cognitive impairment and the need for external assistance to provide glucose, glucagon, or other corrective activity. Hypoglycemia may be documented by Whipple's Triad. Symptoms consistent with hypoglycemia: a low plasma glucose concentration measured with the precise method, and relief of symptoms after the plasma glucose level is raised. Etiology and risk factors of hypoglycemia include the conditions due to excess insulin, such as erroneous injection of insulin, e.g. dose miscalculation or injection of incorrect insulin type, deliberate overdose, lipohypertrophy at injection sites, causing variable insulin absorption, bariatric surgery, can cause hyperinsulinemia. Due to increased sensitivity to insulin, such as exercise, weight loss, sudden reduction in glucocorticoid, unrecognized Addison's disease. Due to reduced carbohydrate intake or increased metabolic demand, such as irregular or missed meals, gastroparesis, bariatric surgery, malabsorption, early pregnancy, breastfeeding. Due to reduced gluconeogenesis and/or glycogen reserves, such as alcohol, chronic kidney disease, advanced liver disease. Due to increased glucose variability, such as long-duration type 1 diabetes or insulin-treated type 2 diabetes, young age of onset of type 1 diabetes. Due to reduced ability to detect hypoglycemia, such as impaired awareness of hypoglycemia, rapid improvement in and/or strict glycemic control, older age, dementia, sleep, no or inadequate glucose monitoring, and so on. Physiology of glucose counter-regulation. Plasma glucose concentrations are normally maintained within a relatively narrow range, roughly 70 to 110 mg per deciliter, that is, 3.9 to 6.1 millimole per liter, in the fasting state, with transient higher excursions after the meal. Between meals and during fasting, plasma glucose levels are maintained by endogenous glucose production, hepatic glycogenolysis, and hepatic, or renal, gluconeogenesis. Although hepatic glycogen stores are usually sufficient to maintain plasma glucose levels for nearly 8 hours, this period can be shorter if glucose demand is increased by exercise or if glycogen stores are depleted by illness or starvation. A decrease in insulin secretion is the first line of defense against hypoglycemia. Counterregulatory hormones, glucagon and adrenomedullary epinephrine, play a primary role. Glucagon stimulates hepatic glycogenolysis and gluconeogenesis. Adrenomedullary epinephrine also stimulates lipolysis with the production of glycerol and fatty acids. Epinephrine becomes critical when glucagon is deficient. When hypoglycemia is prolonged beyond nearly 4 hours, cortisol and growth hormones also support glucose production and restrict glucose utilization to a limited amount. Both mechanisms are reduced by 80% compared to epinephrine. Thus, cortisol and growth hormone play no role in defense against acute hypoglycemia. The threshold shifts to lower than normal glucose levels in people with recurrent hypoglycemia, i.e., patients with intensively treated diabetes or an insulinoma have symptoms at glucose levels lower than those that cause symptoms in healthy individuals. Clinical manifestations of hypoglycemia. These include autonomic symptoms, neuroglycopenic symptoms, and nonspecific symptoms. Neuroglycopenic symptoms of hypoglycemia are the direct result of CNS glucose deprivation, such as behavioral changes, confusion, fatigue or drowsiness, irritability, anger, incoordination, seizure, loss of consciousness, cardiac arrhythmias, and if hypoglycemia is severe, death. Neurogenic, or autonomic, manifestations of hypoglycemia result from the perception of physiologic changes caused by the CNS-mediated sympathodrenergic symptoms, mediated largely by norepinephrine released from sympathetic postganglionic neurons but perhaps also by epinephrine released from the adrenal medullae, such as palpitation, tremor, and anxiety, as well as cholinergic symptoms, mediated by acetylcholine released from sympathetic postganglionic neurons, such as sweating, hunger, paresthesias. Clearly, these are nonspecific symptoms. Adrenergic symptoms are less prominent or may be absent in some patients, especially those on beta blockers. For these patients, symptoms related to decreased cerebral glucose predominate. They range from lethargy and confusion to combativeness and agitation. Common signs of hypoglycemia include diaphoresis and pallor. Heart rate and systolic blood pressure are typically increased but may not be raised in an individual who has experienced repeated, recent episodes of hypoglycemia. Neuroglycopenic manifestations are often observable. Transient focal neurologic deficits occur occasionally but permanent neurologic deficits are rare. You might think why pallor occurs in hypoglycemia. The reason behind this is hypoglycemia also reduces the protective nitric oxide-mediated arterial vasodilator mechanism in healthy, T1DM, and T2DM individuals. Hypoglycemia in diabetes. Hypoglycemia is a fact for people treated with insulin, sulfonylurea, or glycides. They suffer an average of 2 episodes of symptomatic hypoglycemia per week and at least 1 episode of severe, at least temporarily disabling hypoglycemia each year. An estimated 6 to 10% of people with type 1 diabetes die as a result of hypoglycemia. Hypoglycemia is lower in type 2 diabetes than in type 1 diabetes. However, its prevalence in insulin-requiring type 2 diabetes is surprisingly high. In fact, as patients with type 2 diabetes outnumber those with type 1 diabetes by 10 to 20-fold, the prevalence of hypoglycemia is now greater in type 2 diabetes. Insulin, sulfonylureas, or glycides can cause hypoglycemia in T2DM. Hypoglycemia-associated autonomic failure. In early type 2 diabetes mellitus, there is relative beta cell failure. In the early phase of uncontrolled type 2 diabetes mellitus, insulin therapy is given for a short period of time. During therapy, marked absolute hyperinsulinemia might occur, which leads to a fall in glucose levels and thus an isolated episode of hypoglycemia. However, in advanced type 2 diabetes and type 1 diabetes, there is absolute beta cell failure, thus insulin is the mainstay of treatment. So there might occur relative or mild to moderate absolute hyperinsulinemia causing a fall in blood glucose levels. As there is absolute beta cell failure, thus there is no decrease in insulin or increase of glucagon in response to falling blood glucose levels, thus leading to episodes of hypoglycemia. With repeated episodes of hypoglycemia during exercise or sleep, attenuation of the sympathoadrenal response to hypoglycemia occurs. This leads to decreased adrenomedullary epinephrine responses and decreased sympathetic neural responses, which cause defective glucose counterregulation and hypoglycemia unawareness, ultimately resulting in recurrent hypoglycemia. Hypoglycemic unawareness. With repeated hypoglycemia, the attenuated sympathoadrenal response, largely the reduced sympathetic neural response, to hypoglycemia causes the clinical syndrome of hypoglycemia unawareness, that is, loss of warning adrenergic and cholinergic symptoms that previously allowed the patient to recognize developing hypoglycemia and therefore to abort the episode by ingesting carbohydrates. The affected patients are at a 6-fold increased risk of severe hypoglycemia during intensive glycemic therapy of their diabetes. Diagnostic testing. It is made at the patient's bedside with capillary glucose testing and confirmed in the laboratory with serum glucose testing. Further evaluation depends on the patient's clinical improvement and possible precipitants. However, hypoglycemia and altered mental status can be an initial presentation of sepsis. Therefore, patients should undergo additional workup including blood cultures, lumbar puncture, antibiotics, and admission if an appropriate clinical picture exists. Treatment of hypoglycemia. It depends on its severity and on whether the patient is conscious and able to swallow. Levels 1 and 2 hypoglycemia should be reversed with fast-acting carbohydrates, repeated measurements of glucose, and, if necessary, adjustment of glucose-lowering therapy. Options available include oral fast-acting carbohydrate, 10 to 15 grams, is taken as glucose drink or tablets or confectionery, that is 5 to 7 dextrosol tablets, or 4 to 5 glucotabs. Repeat capillary glucose measurement 10 to 15 minutes later. If still less than 4.0 millimoles per liter, repeat the above treatment. If blood glucose remains less than 4.0 millimoles per liter after 3 cycles, 30 to 45 minutes, contact a doctor. Consider glucagon 1 mg IM or IV 10% glucose, 600 to 800 milliliters per hour. Caution in renal and cardiac disease. Once blood glucose is more than 4.0 millimoles per liter, take additional long-acting carbohydrates of choice. Do not omit insulin injection if due, but review the regimen. Level 3 hypoglycemia may also be treated with oral carbohydrates if the patient does not have impaired consciousness. If parenteral therapy is required, then as soon as the individual is able to swallow, oral glucose should be given. If the patient is unconscious or fitting or very aggressive or nil by mouth, parenteral treatment is required. IV 75 ml 20% dextrose over 15 minutes, which equals to 15 gram. Or IV 150 ml 10% dextrose over 15 minutes. Or IM glucagon 1 mg may be ineffective in undernourished people with severe liver disease and with repeated hypoglycemia. Caution in hypoglycemia induced by oral glucose-lowering therapy. If the patient is conscious and able to swallow, but confused, disorientated, or aggressive, give 2 tubes of 40% glucose gel, squeezed into the mouth between teeth and gums. Repeat blood glucose measurement after 10 to 15 minutes and if ineffective. After 3 cycles, call the doctor and consider IM glucagon, 1 mg, or IV 10% glucose. Full recovery may not occur immediately and reversal of cognitive impairment may not be complete until 60 minutes after normoglycemia is restored. When hypoglycemia has occurred in a patient treated with a long or intermediate-acting insulin or a long-acting sulfonylurea, such as glibenclamide, the possibility of recurrence should be anticipated. To prevent this, infusion of 10% dextrose titrated to the patient's blood glucose, or provision of additional oral carbohydrate may be necessary. Octreotide in combination with dextrose has been recommended as first-line therapy in the treatment of sulfonylurea-induced hypoglycemia, especially when it is refractory to dextrose therapy alone. All patients on OHA, that is sulfonylureas, should be observed for an extended period, either in the hospital or an emergency department observation unit, depending on hospital custom, because these drugs have long biological half-lives and a propensity for causing prolonged and severe hypoglycemia. Patients with diabetes who are not on OHA can be discharged home following a short period of observation if they have an appropriate response to treatment and are able to eat without difficulty. Advice should be given regarding the consumption of regular meals, including snacks, and the warning symptoms of hypoglycemia. If they are on insulin, the dose of insulin can be reduced until they follow up with their physician. Thanks for watching. Stay tuned for the next video.